The degree of staining will vary with the amount of meconium passed. If the fluid is thick, there is an increased likelihood of fetal distress. Observe the fetal heart rate monitor strip for poor variability, or a sinusoidal pattern, which is curves of long-term variability of up to 30 beats per minute that undulate regularly around a fixed baseline rate. A severe decrease in variability and late fetal heart rate decelerations are ominous signs in the presence of heavy meconium staining. When the infant is born, carefully assess respiratory effort. Prepare intubation equipment for deep endotracheal suctioning, and place the infant in supine position with the airway in neutral position. In any case, however, you will suction the newborn's mouth and nose and have oxygen readily available. Observe the infant for color, perfusion, signs of respiratory distress such as grunting, flaring, retractions, or apnea. If the infant's respiratory status is compromised, the team will begin stabilization procedures and will transfer the newborn to the neonatal intensive care unit. With heavy meconium staining, the newborn is at risk for meconium aspiration syndrome, pneumonia, pneumothorax, pneumonitis, persistent pulmonary hypertension, asphyxia, seizures, renal failure, and death. Now let's move on to labor induction. What is your role? Sometimes nature doesn't readily take its course, and the process of labor needs a push. Induction of labor involves stimulating the uterus to contract before the spontaneous onset of labor. Augmentation of labor is the stimulation of uterine contractions after labor has started, but is not progressing satisfactorily. Stimulation of labor is most commonly achieved by amniotomy, or rupture of the amniotic membranes with an amnihook, insertion of either prostaglandin gel or laminaria for cervical ripening, or infusion of intravenous oxytocin to initiate or intensify uterine contractions. Maternal indications include an infection in the amniotic sac or chorioamnionitis, pregnancy-induced hypertension or chronic hypertension, insulin-dependent diabetes, preterm, premature, or prolonged rupture of membranes, and postterm pregnancy. Fetal indications for induction include a low biophysical profile, fetal intrauterine growth retardation, potential for or actual fetal jeopardy, such as with postterm gestation, maternal fetal blood incompatibility, and oligohydramnios. Prior to the actual induction of labor, several diagnostic tests will probably be performed. These include a non-stress test for fetal well-being, gestational age assessment via ultrasound or amniotomy, assessment of fetal lung maturity by lecithin sphygmomyelin ratio, a Bishop score for assessment of the cervix and fetal descent, and cervical ripening exam. If an amniotomy is done, check the fetal heart rate before and immediately after the procedure to detect cord compression or cord prolapse. Observe and record the time of the rupture of membranes and the color, odor, and consistency of the fluid. After the amniotomy, monitor the maternal temperature every 1 to 2 hours. Assess the client and her fetus for signs of infection, such as maternal chills, fetal tachycardia, uterine tenderness, and foul-smelling vaginal drainage. Because there are wet underpads and increased vaginal discharge with an amniotomy, be sure to cleanse the perineum and replace the pads frequently. Observe for any changes in labor pattern and assess and record the client's intake and output. When oxytocin is administered, observe the fetal heart rate for the 20 minutes before the start of the induction to identify fetal baseline. Then infuse oxytocin via a secondary line, called a piggyback, so that it can be stopped in an emergency without discontinuing the primary or maintenance infusion. Again, you will assess and record vital signs, intake and output, and signs of water intoxication frequently. Oxytocin has some antidiuretic properties, so you must be aware and monitor for signs of water intoxication. They are headache, blurred vision, increased blood pressure and respiratory rate, rales, wheezing, and coughing. Monitor uterine contractions for hyperstimulation. Contractions lasting more than 90 seconds and occurring more frequently than every 2 minutes, and with a resting tone higher than 20 millimeters of mercury. You will assess fetal well-being continually for signs of fetal distress, such as bradycardia, tachycardia, absent variability, and repeated, late, or prolonged decelerations. If uterine hyperstimulation or non-reassuring fetal heart rate patterns occur, institute the following emergency measures. Turn off the oxytocin infusion and increase the rate of the maintenance IV. Administer oxygen by face mask as prescribed. Place the client in a side-lying position, and notify the physician or midwife immediately.
3 types of medications are used for inducing labor: oxytocin, prostaglandin E gel or suppository, and laminaria. Oxytocin is a pituitary hormone that stimulates uterine contractions. It produces strong uterine contractions in a short time, even at minimal dosages. It is always administered intravenously by piggybacking the oxytocin solution to a primary line. An infusion pump provides the incremental doses necessary for an effective contraction pattern. Uterine hyperstimulation and other side effects appear to be related to the dose of medication. Prostaglandin E gel or suppository is placed intravaginally before labor induction to soften and thin the cervix. You will instruct your client to lie flat for 15 to 20 minutes after insertion to prevent leakage or expulsion. Also be aware that hypertonic uterine contractions are the most common adverse effect. Hydrophilic or moisture attractant G laminaria are placed in the cervix, where they absorb water, swell, and gradually dilate the cervix mechanically. Laminaria is actually made of dried seaweed, but a synthetic alternative has become available. Complications include uterine rupture, amniotic fluid embolus, precipitous labor and delivery, cervical lacerations, postpartum hemorrhage, and water intoxication. Fetal complications are related to fetal distress.
Now for some critical thinking. A 30-year-old Gravida 1 Para 0 is in labor. DS has received prenatal care, and her pregnancy has been uncomplicated. She is having contractions every 2 to 3 minutes, lasting 60 to 90 seconds. The membranes are ruptured, and the fluid has light meconium staining. Her cervix is dilated 7 to 8 centimeters and is 100% effaced. She states, "I can't go on with this." What is your primary intervention at this point in time? A. Stay with